Hello, everyone. Hope you're having a great day so far. I'm Dan Pierce, one of the founders of Mentally Fit. And today we have another great talk for you. We have Rachel Needle and Dr. Joe Kort, who are the directors of the Modern Sex Therapy Institutes. And today they've got a great talk for us. So let's jump right in. Rachel, thanks for joining us today.
Thank you so much for having me. As mentioned, I'm Dr. Rachel Needle. I'm a licensed psychologist and a certified sex therapist and co-director of Modern Sex Therapy Institutes, where we do continuing education training and certifications such as sex therapy certification, LGBTQI affirmative therapy certification, and about 10 others, new sexual trauma certifications launching at the end of the week. And so please check us out, modernsextherapyinstitutes.com. And I'm excited to be joined by my co-director, friend, colleague, the infamous Dr. Joe Kort. So I'll let him introduce himself.
All right, thank you, Rachel. So this is something that I've taught through Modern Sex Therapy Institutes, and so it's my thing that I'll be doing most of the talking about the work on trauma and sexual health. And my journey has been that originally, like many of us, my training I was trained as a trauma therapist. I was trained in working with addiction and marital work and couples work and all of this. And I was not trained in sexual health, right? So I knew nothing about how to help my couples or help my individuals once they healed the trauma, once they healed whatever was going on in their relationship into their own erotic and sexual thumbprint. And I find that today it's still the case where there's just not an inclusion of sexual health. It's been sort of locked out of mental health, and that's changing. And so I'm hoping that I can initiate more change by doing this talk with all of you. So I'm just going to start. Unless, Rachel, do you have anything else you want to say? All right. Oh, you're muted. Okay. All right. So sorry. Okay. All right. So here we go. So I love to start with this line. It's by a colleague named Doug Braun-Harvey. He's a sex therapist as well. Actually, Doug Braun-Harvey's work is working with chemical dependency and including sexual health, which often doesn't happen either in recovery from chemical issues. And his line is great. When it comes to sex, the most uncomfortable people in the room have all the power. And so what that means is, and it's happened to me throughout all my years, as once I became sexually informed in the early 2000s and started talking about sex, the most uncomfortable people in my audiences hijack the conversation and want to talk about something that's non-consensual. That's not what I'm trained in. I'm talking about consent. That's what today's about. How do you heal trauma and help somebody into consensual sexuality, consensual erotica? Or they want to talk about human trafficking, which is a very important topic, but it's not what I'm going to be talking about, or child pornography or child abuse. All important stuff. Again, not what I'm talking about. And often people do that because they're uncomfortable. And so now that that's what's coming up for them, and I have to help them see that that's not where we're heading. Where we're heading is talking about what happens. And talking about sex can be very triggering for people. Most therapists haven't examined their own sexuality, their own eroticism, their own gender identities. And when you do this work, you have to. You absolutely have to. So I was, and how this actually really started for me, and then I'll keep going, is I was doing a talk on male survivors of sexual abuse. Actually, I was doing mother-son incest. That's another one of my specialties. And a woman in the audience who also specialized in mother-son incest was in my talk. And when I was done, she said to me, "That was a great talk. I'm really glad that I sat through it. And you're missing a whole sexuality piece." And I didn't believe I was. I kind of argued with her. And she said, "You're not talking about what does sex look like for these people after trauma? What does sexual health look like for them?" And to the untrained therapist, which I was, sexual health is often what you think is sexual health. Then you end up leading the client where you think they should go rather than where the client themselves need to go in their own erotic thumbprint. So my work has been to protect our clients from us. We all try to do that, right? Coming to all these trainings, we want to do harm reduction, do no harm, protect our clients from us. That should include sexuality as well. So one of the things that I get a lot of people saying to me is that they've been to therapists who have pathologized their sexual behavior and erroneously connected it to the early trauma, right? And I feel this way as a trauma therapist. I'm going to make a blanket statement. I know not, we all don't do this, but to a man with a hammer, everything looks like a nail, right? So if you're a trauma therapist and you're always looking for trauma, which I used to do, and I still do, you're always going to find it, or you're going to think you found it. Whereas what you want to do is understand that, yes, there's been some trauma, and not every abuse, I always say this, not all abuse equals trauma. We sort of have that misconception in our field. I've had many clients who've been abused, but didn't experience trauma. I've had many clients who experienced abuse and don't call it abuse. So this is like an ever sort of understanding of how do you meet the client where they're at, and understanding that even though they may not consider it abuse. So I'll say to my clients, look, you were 10, the perpetrator was 40. That's abuse. It's abuse of power. I hear that for you, you don't experience it that way. And I've actually had clients say to me, if you insist on calling this abuse, I'm going to fire you. This is not my, I don't see it this way. This was my first sexual experience. It was my sexual debut. In sex therapy, I'm going to try to introduce you to some concepts and terms that we use in the field. But we don't say losing virginity. We say your sexual debut, because losing one's virginity may not be the sexual debut. Your first sexual experience might have been trauma, abuse, or just not what wasn't your thing. So that's not your sexual debut. It's what you decide, looking back on what was sexuality for me, what was erotic for me. So I'm going to keep going. And, sort of to help you understand this, let's see. Sorry, I have to go. That we really want to affirm your own client's sexuality, their attitudes. I just was working with a supervisee a minute ago before this, and she was saying, how do I help my client? He's from a culture that's against the kind of sex he likes, and but he enjoys the kind of sex he likes. How do I help him reconcile that? What do I say to him? You don't. You help him or her or whomever reconcile it themselves, find their own individual self around this, and then now and understand I have this other thing, my religion, my culture, my race, whatever it is that has these other messages. How do I reconcile both? Not the therapist. This is a client-centered thing. I've seen this forever. I've also specialized in LGBT. I'm gay myself, and I'm here in Michigan, and right outside Detroit, and many of my Asian American clients that are LGBT, Black American, Middle Eastern. We have the highest population of Middle Eastern in Michigan. We actually have the highest population of Black in Detroit. And they'll come to me and say, I will never, ever come out as a gay LGBT person because my race, my culture, my religion, whatever, would alienate me, and my family's more important to me than having a big coming out process. So I'm going to heterosexually marry, and my old self in the 90s would not tolerate that because I was so gay affirming. I was so LGBT affirming back then. Today I understand and sit with clients, and I'll say you can't change your orientation, but you absolutely can make a choice to not act on it if, for you, your intersectional identity, the main one is your race, your religion, your ethnicity, whatever that is. So in sex therapy, we try to help therapists address their own blind spots and their own bias. And believe me, we all have them. We're human. And so you're going to examine your own sexual history, your own abuse history. You should do this anyways, even if you never become a sex therapist, because those things will get in the way, and they do. And what ends up happening is if you're working with a couple who are experiencing trauma or have histories of trauma, you're going to inadvertently align with the partner that you agree with. And that's not helpful. That's not helpful to the partner you don't agree with. It's really staying out of the way and letting them come to their own erotic answers, their own sexual answers. So let me say that you hear me talk about two different things, sexuality and eroticism. I make this distinction. We have a sexual orientation to whom we're attracted to, male, female, both, a blend of both, neither. But then we have an erotic orientation, the things that get us off, the things that bring us to orgasm, the things that are create and contribute to our fantasies. Sometimes that comes from early trauma. Um, Oftentimes it comes from whatever we've had in our life, any negative influencing, any positive influencing. So I'm going to get to this as I go on, but as I'm thinking about it, I'll say it now. A lot of therapists erroneously think that kink and fetish behaviors automatically come from trauma. And we have no research to support that. In fact, the research supports otherwise. It supports the fact that all things from childhood can get eroticized. And the thing about kink, when it gets eroticized from trauma, is that what people are doing is working through their trauma in the kink. They're working through their trauma in the fetish. And that's not necessarily pathological. Pathological would be if they're doing it and putting themselves or someone else at risk. But if they're doing it in consensual ways, negotiated ways with partners, that in and of itself has been researched to show it can be really helpful, like helping kids with play therapy. Really, our sexual connections and play with partners is all like play. We're playing out all kinds of things that are in our heads and are from our backgrounds. So, and without understanding kink and without understanding fetish, you're going to be lost. Like, you're not going to understand that for many people in the kink community, they don't have intercourse. They're having a lot of outer course, or they're not having sex at all, or it's not genitally focused at all. And you might inadvertently think, well, that's from your trauma, right? Because this happened to you, and I know what happened to you. Now you've disowned your genitals or disowned your sexuality, and that's why you're into this. Maybe not, because many people in the kink community who didn't have any trauma also don't. You can be kinky and asexual at the same time, because it doesn't necessarily involve sexual contact. It doesn't involve necessarily orgasm. It's complicated. I may be making it more complicated for you as I'm talking, but that's great. You want to be thinking, and you want this kind of controversy in your head. You want to come to another place in this that makes more sense for the client, and not from erroneous beliefs that we received in the mental health field or even growing up that aren't helpful to people. And you want to manage your own disgust response, because here's what happens. When I feel disgusted, then I'm going to make you disgusting. I see this in couples all the time. I'm disgusted by what you did, and sometimes their disgust is from their trauma, is from things that happened to them, and now they put it and they project it onto a partner. So you want to try to clean all that up. And so I'm going to give you an example of how to do that. I'm going to talk about a case that I had where a guy came in. So I see a lot of, I don't only see this, but I do see a lot of straight men who have sex with men. I see a lot of male sexual fluidity, let's say that, and a lot of male sexuality. And his wife walked in on him masturbating to webcam sex of other men. They were from the torso down, so was he. So it was really just focused on the genitalia, and he was imagining himself giving them oral sex. This looked gay to her. He'd never talked about it with anyone, so he didn't know what it was. He hadn't put a label on it, but they came in crisis into my office because they didn't understand what was happening. And he was compulsively doing this. This was just at a point where he was caught. So when I do a genogram within 2 or 3 sessions when I work with people. And within his genogram, his sexual history, his family history, what came out was when he was 10, he was with his 15-year-old male cousin and brother, and they were chewing gum. And he said, I would love to have a piece of gum. He was 10 years old. He wanted to be one of the boys, right? And they said, sure, you can have a piece of gum if you give us oral sex. He said, I'm not doing that. They said, then you can't have any gum. He thought about it for a little bit. He was 10 years old. They were 15. He said, I'll do it. So the male cousin pulled out his penis. He went to perform oral sex. But before he could, they threw him to the floor. They spit their gum out on him and told him he was a fucking faggot. And they knew it all along and stopped talking to him for a long period of time. He never told a soul. This was trauma for him. So now what is he doing on webcam? Returning to the scene of the sexual crime. So now we have a guy who keeps going back to the original problem, which was or incident where he was going to give oral sex. But now it's gotten eroticized, right? It's become eroticized to manage it, to understand it, to tolerate it. So now the work begins, and I put this together for him, and he sees it. He starts crying. he connects the dots. The wife understands. So we do individual work, couples work. I throw him into a men's group. We do EMDR. I sent him to the Mankind Project. If you don't know about it, it's a wonderful group for men. mkp.org. I get no money from it. I'm just very passionate about it for referring to it. I love it. Actually, I did it myself. And so he does 2 or 3 years of healing around this. And in the end, what happens is he's no longer compulsively doing this, but he still wants to do this. And a lot of trauma therapists don't understand this. They think, well, then it's still trauma reenactment. No, you go from trauma reenactment to trauma play. That's different. Trauma reenactment is I break my relationship agreement. I'm compulsively acting out. I'm putting myself or other people at risk. Trauma play is I make an informed consent with my wife or my partner. I negotiate consent with other people doing this, and I'm in control of it rather than it being in control of me. And that's recovery. That's sexual health for this client. I can't say it's for every client. I'm not going to stand here and say that everybody has the same ending. But I am going to say that for a therapist to say that there should be the same ending for everyone else, that's not helpful. That's unethical, in my opinion. This man, for this time in his life, because it happened to him so young, it is now an imprint. And most of the people, though, are going to come in. You're going to have clients come in and they're upset about it. You know, this happened to me. My uncle did this. My aunt did this. My mother. And you're telling me that I have to live with this? No, I'm telling you to make friends with this and understand that the first time it happened, it was non-consent and it was abuse. But you might find that as you do the work, now it's yours. You get to play with this. And the truth is, like I started out my talk, everything from childhood can get contributed into the sexual narrative. And one of the ways to understand this in terms of working with clients is I call it cracking the erotic code. So in other words, there's an erotic code that's embedded in that sexual narrative that's non-sexual. And if you tell me all the details of what you're interested in, what you're doing sexually and erotically, I can then help you, if I've done the genogram, possibly look back and see what things are from what. Not everything is from something, but some things are. Like, so let's talk about this. This isn't trauma, nor is it abuse, but it affected the client. I had a client who was into women who were amputees. And you didn't need to watch porn. You can just get on the internet and watch it on YouTube and, you know, and just watch a woman trying to get around without a limb, a leg, one or both legs. Very erotic. And it was concerning him. He felt a lot of shame. And because also the Me Too movement, he didn't like objectifying these women. It turned out that he was raised in a household with a fully able-bodied mother, but she was so depressed she couldn't get off the couch. So they lived on government assistance. Across the hall was a woman who had a missing leg, but she worked every day and went up and down the stairs from the apartment, and he would offer to help her with groceries, and she would say no, but you know, come and be my visitor, you know, like keep me company. And so when his sexual orientation kicked in, it was to women. When his erotic orientation kicked in, it was to women who were amputees. Now, a lot of people may look at that as, well, maybe he was traumatized as a child and maybe it is linked, but it doesn't matter even if it is. What matters is to help him do that work and recover from what happened to having a depressed mother. But our fantasies right the wrong. We go from victim to victor. That's what that's all about. And it's an attempt toward health, not attempt toward pathology. And the more you pathologize somebody's fantasies, and the more you even give into, you know, a lot of clients come in and they say, I want this out of my head. Slice it out. I don't care how you do it. Well, I always tell couples and individuals, there's no such thing as an eroticectomy. You can't have an eroticectomy. You can't cut it out. You can learn to lower the volume. You can add to your sexual and erotic interests, but you can't necessarily get fully rid of kinks, fetishes, and strong early imprinted fantasies that happen from childhood. And then there are things that aren't related to trauma. I've had clients, especially males, who their first sexual, their debut and the things that they got into were watching female relatives. Heterosexual little boys will sneak peeks at female relatives. Gay and bi little boys Well, gay little boys will do it to male relatives. It's normal. And bi little boys will do it to both. Um, so I've had one client who, because he was watching his sister and she didn't know, when he would masturbate to it, she had unshaven pubic hair in her lower genitals, and that's all he liked as an adult. That wasn't abuse, that wasn't trauma. It was his first sexual experience. One guy told me that when he was abused, it was a man with a hairy chest. He was 10, the guy was 40. Father of the best friend he was sleeping over. So now he's only interested in men with hairy chests. If you move those clients and put them at war, as they already are, with their sexuality, they will lose, and it will cause more chaos and problems than when they started. So this is a very good quote by an author and sex therapist, the late Jack Morin, Morin, and he wrote a book called The Erotic Mind. And this is not a quote from there, it was a quote from his website before he died. He said, if you go to war with your sexuality, you will lose and cause more chaos than when you started. So that's really important. So when I say someone goes from trauma reenactment to trauma play, what you want is helping people, and this I'm looking at notes I put together. The World Health Organization, when they wrote up their code for sexual health, I'm not going to read the whole code. You can go see it. They revised it, I think, in 2012. But basically, they include the words that sex should include pleasure, safety, and your sexual rights should be protected. So Doug Broughton Harvey, I'm going to refer to him again, talks about managing pleasure and safety with protecting sexual rights. As long as people are moving in that direction, even if it comes from trauma and it's now become trauma play, that can be a source of healing. Now, it can't be for everyone. Please don't leave this talk and think, well, Joe Kort said this, so it's true for everyone. Of course it's not true for everyone. But I'm giving you a narrative that we haven't been given before. We weren't given this narrative that things that, around sexuality, we were taught about trauma. So what I was taught was this. I think it's still taught this way. Once you heal the trauma, your sexuality will surface. Your healthy sexuality will surface. Not necessarily. In fact, mostly not. You have to go and dig in for your healthy sexuality. So I always say that sexual abuse will disorient you. It will not orient you. So in other words, sexual abuse doesn't make a sexual orientation. It confuses your sexual orientation. So there's a lot of questioning people have about, am I gay? Am I straight? Am I bi? Am I gay because of this? Am I not gay because of this? But your erotic orientation is shaped by things that happen in your childhood. Now, some things aren't shaped. I have one guy, actually, I run a podcast, I do a podcast, Smart Sex, Smart Love is the name of it. And my very first podcast, I called them the Ropers, not the Ropers from Three's Company, the Ropers, like BDSM. And the guy realized he liked tying up his partners consensually when he was a Weeblo, like a Boy Scout. And he was learning to tie knots, and he had an erection. He was turned on. And so where did that come from? Who knows? Spanking fetishes. Some people, it comes from being spanked. For others, the first time they were spanked, even if they were 3, 4, 5, they remember it vividly because it was arousing in the developmental way that it could be for the 3 to 4 to 5-year-old. So, and then the other thing that people do is they think, well, trauma is going to lead to unusual or unusual sexual interests or unusual sexual fantasies. Be careful with that, because some people through trauma, their defense and their reaction is to become normative or heteronormative. So some people, because the abuse was so awful for them, their defense and their answer is, I'm going to change my life and make sure that everything is normative and everything is exactly the way everyone else's is. And that may not be right for them, because what we're learning in research of people that are kink and fetish is that may be their sexual orientation. So if they're a dominant person, a submissive person, that may also be an identity, just like LGBT. And when you talk to people in the kink and fetish community, they say, it does feel like that to me. It does. And I don't mean to keep talking about kink and fetish because, but it is what a lot of therapists look at as non-normative. And It's non-normative for a vanilla person. It may be non-normative for you, but it's 100% normal for this person. I had another student, we were talking, and she was seeing an adolescent, and the adolescent was kinky, and she couldn't fathom that. She's like, no, 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 you don't just come out sexually as a teenager kinky. That's something you evolve to. Not necessarily at all. The reason we evolve to it is because we're evolving all the time as sexual beings, right? So, and we may be suppressing it because we only teach children 4 things, the predominant things we teach children. You have to be heterosexual, you have to be cisgender, you have to be monogamous, and you have to be vanilla. If you are not one of those 4 things, good luck, go figure it out. Nobody cares, nobody wants to help. We had a person in my group practice here, a little kid who had a fetish, foot fetish, and parents didn't want to deal with it. They just wanted the whole thing to go away, so they didn't help him manage it. So then later in life, he ended up getting in some legal trouble because he didn't know how to manage his own kinky self. If he had just had a therapist who could have worked with him, rather than parents who wanted it all to just go away, he might not have gotten into that legal trouble. He was not a sex offending kid. He had other issues, and they were a part of his fetish. If there are any questions and I don't see them, I'm not looking in chat. Maybe I should. I don't know, but I'm going to keep going unless somebody interrupts me, which I don't mind. And then I just like to teach, as you're working with trauma, you want to be careful. So we always say in modern sex therapy institutes, don't get left behind. I used to say this as a younger LGBT trainer. If you don't understand LGBT, you're going to get left behind. Your clients are going to fire you. They want you, they don't want you friendly. They want you informed. They don't want you trans friendly. They want you trans informed, trans knowledgeable. The same is true with sex now. Your clients are going to fire you. They want to be able to talk about sex without being judged, without having your agenda overriding them, and the language. They're going to smell you out, right? So LGBT people are listening. Are you using words like homosexual because homosexual is like a bad word in the LGBT community? Are you saying transgendered? You don't want to say that. They're not a verb. It's like saying somebody's Puerto Rican. It's not even a word. So they're listening to make sure, are you trained or aren't you trained? They're listening around sex too. As you're helping me with my trauma, I mean, they may not be listening for that in the beginning because the work is so hard. And I've been through my own trauma training. I didn't come out about this, but I'm a sexual abuse survivor myself. And this was the 90s, and I'll never forget the therapist I worked with wasn't a sex therapist. So in some ways she wasn't so helpful to me, but in many ways she was. And one of the ways was she asked me for every detail of what my sexual fantasies were. Because another thing to know is that when you're traumatized as a child and then you are reenacting it as an adult, yeah, it feels and looks like it's erotic urges, but they're really trauma urges, right? They can become erotic urges, but they're trauma urges because you're reenacting something and it's unconscious. So I want to just teach you to say some words differently, right? So we don't say prostitute anymore. We say sex workers. Understanding this is a profession of people. You may not agree with this. This may conjure up all kinds of stuff in you. But if you don't really get on board around this, you're going to end up pathologizing and giving the message to your client that something's wrong with them or something's wrong with what they're doing. It might be illegal. It's illegal in many states, but it's legal in many places. And it is something that people enjoy getting paid for and enjoy doing. And many times it's related to childhood. In my training, it was always around sexual abuse. All of these sex workers are sexually traumatized from childhood. Not true. We have really good research today that says some are, but many are not. Many understand that this is a way of making some good money. They're attractive enough. Many of them are on lots of different sites, and it's the way it is. If they're doing it online, they're called cyber sex workers, right? We still don't call them prostitutes. And I love this. I don't know who I got this from. I wish I would have gotten their name, but I love saying this. If you mean exploitive sex work, say that. If you mean underage sex work, say that. If you mean migrant sex work, say that. But to call sex work and then be all inclusive of all those things is not helpful and wrong because it's not all the same. And that's important to know, not to minimize those other things. Now, we're talking about porn, we don't say using porn. Porn is not a drug. We watch porn. And we in the sex therapy field mostly are looking at the out of control behavior that a lot of clients come in calling sex addiction. We look at it as compulsive sexual behavior for all kinds of reasons. And we already have existing language and assessments and understandings of why people feel out of control and engage in compulsive behavior. Not every person who watches porn is out of control. Now, the partners may not like it. And so then what ends up happening, sadly, is that a client comes in and says, I think that I have a sex addiction, and my partner concurs. So then many good, well-intended therapists will say, well, then let's get you the books and the writings and the 12-step groups, and let's in a 12-step group. But when you go to the doctor and you would never say to your doctor, well, you might, I think I have kidney cancer and my wife concurs. The doctor doesn't say, well, thank God, let's get rid of that kidney and get you on chemo and radiation. And the doctor says, slow down. Let's understand why you feel that you have this, because it may not be kidney cancer. There are legitimate tests and legitimate assessments before we take out your kidney. So anyways, we don't call it even porn so much. In our field, we call it erotic imagery, sexually explicit material, just to take away the judgment and the pathology out there. And some people are compulsively using porn to work through early childhood trauma. I had a guy who came to me, and he was heterosexually identified and married to a woman, but he enjoyed watching gay porn, medical porn. Somebody was a doctor, somebody was a patient, and they were having procedures done. I mean, not it wasn't like watching a medical show, but it was all play acting of that. And it went against his values because he wasn't gay, and his wife didn't understand why you're watching this. Well, he was sexually abused by his doctor, and so were all the neighborhood boys. So he was working through the abuse by watching the porn. So it became compulsive for him. Once we worked through the abuse and he named it and understood it, that porn still turned him on. Sometimes it doesn't for some men, but it still turned him on, and it didn't matter to him. And he and his wife understood it from a different perspective. You want to just really step away from pathologizing sexual behavior. Now, I'm only talking about consensual sexual behavior. I'm not talking about non-consent. The more you pathologize and align with your client who pathologizes, the more trouble you're going to make for that client and their relationship. So I really encourage you not to do that. So what people do is, I think I already said this, that if they come in and they have tension, like I had a guy come in, and he was gay, he was religious, and he was heterosexually married. And he called himself a sex addict because he kept acting out with men. And I didn't agree with that. I said, I think it's something else. I think you have choices here. You're doing three things. You want to be heterosexually married. You love your wife. You want to engage in sex with men, and you want to stay attached to your religion. And the sex with men is the one that's got to go. And you're unwilling to do the grief work that it's going to take to say at 40 years old, for the rest of my life, I'm never going to be sexual with another man, because it goes against my religion and it goes against my agreement with my wife. That's the work that he needed to do. Calling it anything else is distracting us from the actual grief work he had to do. So let's see. I've talked about a lot of things already. I kind of went ahead of myself, but and so then early trauma can also contribute to sexual dysfunctions, performance anxiety, performance issues. I don't know if any of you know this, if many of you are EMDR trained, but I am. And one day, many years ago, I had a client who had severe sexual abuse and all kinds of stuff. And now it started to hinder his erectile performance with, and by the way, we don't call it erectile disorder or dysfunction anymore. I may do it because I'm older and I'm trying to learn the new language. The newer way to say it is erectile disappointment. So much better. Such a better language, so that the guy doesn't feel like something's wrong with him. It's disappointing that my erection isn't coming on demand the way it always has, but we need to figure it out. It's disappointing, and we'll figure it out. So anyways, one day I decided to do EMDR. I thought, why not? EMDR is all about discharging the emotion, and it's his anxiety that's getting in the way, causing him to have lose erotic focus when he's with his partner, especially because of the abuse. And we had done tons of work on the abuse. So I did it, and it worked. And I did it on another guy, and it worked. And I did it on another guy where he didn't have any trauma, and it worked. And I'm not part of the EMDR community, so I have to be honest. My ego went, oh my God, they're going to make the joke Kort protocol. I have cured erectile disappointment by EMDR. So I got on the listserv. I'm like, has anybody else seen this? And of course they had. And it had been done for years. But that's another thing about the EMDR community that I experienced. They don't talk about sex. They don't talk. The therapists are more than happy to talk about sex when it's through the lens of trauma and abuse and horror and nightmare. So I've always seen this in all 36 years of my being a therapist. If I do a talk on sexual abuse and trauma, the room is packed. If I do a talk about sexual pleasure and sexual joy, a third of the room shows up, and that's it. Therapists have an allergic reaction to talking about it in terms of pleasure and joy. And we need to be able to do both. That's why I'm doing this talk. We need to be able to do both. I have a lot of feelings around this because I never did. I wasn't doing both. Let's see, I'm going to keep looking for what else I wanted to say, but I pretty much said, okay, so then there are people that come in that are asexual, right? And a lot of therapists, now our job, of course, is to look at abuse, look at neglect, look at trauma, look at problems, look at pathology. So it makes sense that when someone comes in and they're asexual, so what does asexual mean? It can mean a lot of things. It makes sense that a lot of people think, because people who've been sexually abused often shut down sexually and appear asexual or present asexual, or even think to themselves and say to you, I'm asexual, when they're not, right? But you can't really say that. I don't say that to any of the people that come in. They identify as ace. They'll call themselves ace. This is tricky. I don't have a good answer for how to understand. You want to rule out, is this from medication? The fact that you have low to no sex drive. Is it from early childhood trauma? Is it from hormone issues that you need a hormone panel, go to the doctor and see if testosterone and estrogen is and what's going on with you? And then some people are truly ace. And so you need to understand that, and I've actually been guilty of this until recently even, where people that are asexual can still have a sex drive, right? And they can still have sexual desire. They just don't desire to be with people at all or anything. They just enjoy it within their own body. So I used to say to clients, I don't say this so much. I mean, I look for it, but a client will say, yeah, I'm not sexual with my partner. And asexuals end up getting married to sexual people because they don't know they're asexual. There's no permission to know that either. And so now they're in this partnership, and they're not having sex with their partner. They may have been able to have sex with their partner for a period of time, because some asexuals can do that, but then it stops. They go back to their own asexuality. And so I used to ask them, well, are you sexual with yourself? Are you masturbating? And they'll say yes. And I used to say, well, then you do have sexual desire. We need to find out what the problem is. Why can't you translate that to a partner? Nothing wrong with that. I think that's something to consider, but you also need to consider that person could be ace, could be asexual. Now, some people are gray sexuals, so they're able to be sexual with other people, but not in the same way the rest of us are. Like lesbian, gay, bisexual, transgender, and heterosexual people can be walking around sexual desire and can freely choose how many people they want to be sexual with. Gray sexuals feel a limitation to it. They're not as inclined to be sexual with people, but they'll do it more than aces. And then there's demisexuals, and demisexuals are people that are only sexual and only feel their sexual desire to somebody they have a connection to. An emotional connection has to be there, but they don't have any other sexual interest in other people. It's only when that emotional connection happens. And it's easy to pathologize these things because they're not normative. They're not things that we've been taught to learn. And the other thing is that asexual people can be romantic. So it looks like what happened to you, and maybe nothing happened to you. They're just asexual and romantic. Let's see. I'm just making sure I'm not getting any questions. Let me pause for a minute. Are there questions?
Yes, we do have some questions, but if we could do them at the end, that would be great.
Oh, sure. Okay. No problem. So let me just see what else I have. I already said this, and I think it's really important that many people use kink and engage in behaviors. And it doesn't have to be just kink. It can be any sexual behavior that resembles their childhood abuse. Then they're working it through, and it is their way of working it through. And it doesn't mean that working it through means I never do this again. It might just mean that now I'm in control of it. I enjoy doing it. I find play partners. Oh, so I had this other client where so this was really, it was the 90s, so it was before the internet. He was in his 30s, and what he did was had out of control behavior around his going to daycare at night when they were closed, picking up urine-soaked diapers and taking them home, putting them over his face and masturbating. He'd been doing this for years. He actually had rosacea on his face. It was so bad. And I don't know how I think he came to me on his own. And so he was in group, he was an individual, and in his history with the genogram, he had an older sister. She was 10 years older than him, and she hated him. She was the only child. She was the special child and chosen child, and then he came along, and she was so upset. So, and he recalled that the first time he ever put a urine-soaked diaper on his face and masturbated was when he was 2 or 3, and back in his day, when he was young, he was still wearing cloth diapers. So it might have been younger. I don't know when kids get out of their diapers. I don't remember the age, but he was super young. And I remember thinking and saying to him, kids just don't do that. You know, that's like learned, like how to, and I always thought to myself, the sister might have been the one to do it. Somebody did, but he just kept doing his work and trying to stop the behavior. And then one day he went to a funeral and asked an aunt if she had ever seen his sister doing anything negative to him, any abuse or anything. And she said, the only thing we ever saw was one day we came in, she was changing you and you were in a diaper over your face. And that's all we saw. She didn't see pins. We didn't see the masturbating or anything like that. But that was enough to know that that's probably where that came from. Now, this work we did helped him no longer go to daycare and put himself at risk. Who's going to believe him? If the police come and say, even though it's after hours, you're in a daycare, you're getting these diapers, you're a child abuser, nobody would believe him. So he needed to find a way. Now this was part of his erotic imprint. This was part of his erotic orientation. So now what the work was to find a woman who was heterosexual, who was into diaper play, who was into the same kind of thing that he was. And sadly, we're not a culture that does that. Gay men do this. If I could show you, I could get on my phone on a gay app and show you that we talk about what we're into before we even meet you. It's right in our write-up, and it's right before we even talk about I have this example where a guy says, I like to, well, I don't know how explicit I can get here, but I like to do all these really explicit sexual things. That's how he starts. The next part is, I love long walks. I love romantic dinners. I love cuddling. That he started with the sexual part, and it's culturally relevant. And because that's what we do. We want to know before we fall in love with each other. So straight people don't do this. Mixed sex couples don't do this. So you don't know until you're into this relationship. So that's another talk. But mostly we need, as therapists, to be able to ask the right questions. You need to know how to do a sexual history and how to ask the questions. I have a friend, I love him to death. He's a newer therapist. He's a little younger than me. And I asked him, all right, so you're a newer therapist, so how's it going? Are you getting people to talk about sex? He said, no, I don't. And I said, well, why not? He said, because they don't bring it up. And I'm like, well, why don't you bring it up? And he said, because why would I bring up something and enter it into the therapy room if the client didn't? And I said, well, do you bring up family of origin, or do you wait for them to talk about their mother? He's like, no, I ask about their mother. Of course I do. Well, why do you bring that up if that's not in the therapy room? Do you see? It's like, that's how we have bias, our disguised our biases are, right? So if you bring up the mother and you bring up the father, then you absolutely should be able to bring up sex. And I feel strongly about this, that it's almost unethical in working with people, not asking about sexual health and checking in. Now, clients may not want to do it, and they have an allergic reaction to it sometimes if they've been abused, especially when they feel shame of getting into the very thing that their perpetrator did to them. That's hard. That is really hard. But I really stress when I work with the clients is that was about them, and that was about non-consent. You can't compare what you get into now to that. Yes, it's the same storyline. It's the same actions you're taking, but this is yours. Now you get your, like I said this earlier, you get your chance to play with this. I don't know that I have a lot more to say. I think this might be a good place to ask questions. I don't think I have a lot more. So.
Excellent. Dr. Joe, that was very, very enlightening, very interesting. So much to process, but very great stuff. Thank you. So we do have some questions here from some therapists. The first one is, are there any good picture books or resources that explain sexual abuse of boys for children?
I do not know of any. And that's an interesting thing, because you would think maybe not, only because it might be looked at as like child pornography. So I don't know. It's a great question. I don't think there is. But I will tell you that a place to ask that question would be to go to malesurvivors.org.
Perfect.
And that's a great place for male survivors.
Excellent. And we'll help look for some resources on that topic as well. So keep an eye out for those in the group. The next question is, can childhood sexual abuse be prevented? Resources, research, thoughts, and any connections are appreciated. What types of people are working in our society on this problem, and who should I be connecting with as a therapist, is what they asked.
That's a great question. I don't know.
Okay.
My job has always been with adults and after the fact, but I don't know.
Okay, excellent. What are the best resources for sexual addiction?
Well, I have more resources around what we call out of control sexual behavior. That's what we work with in sex therapy, where we let the person figure out for themselves what is out of control and why they feel out of control. So there's a great book by Doug Brown Harvey, and it's called Treating Out of Control Sexual Behaviors, Rethinking Sex Addiction. And what it does, what I like about it is, rather than focusing on the behaviors, the way in which sex addiction does, he focuses on 6 principles. And let me just say them, and then you'll read about him in his book or online. And he's done my podcast. He's all over the internet. Oh, and he's spoken for Modern Sex Therapy Institutes. He's done lots of stuff. We have a whole series of him working using this alternate model. But so based on the principles, there's 6 of them. He believes that you can recover and have recovery around sexual health if it's consensual on both parties, number 1. Number 2, non-exploitive on both parties. Protected, number 3, so for safer sex and unwanted and protection from unwanted pregnancies. Honest on both sides, shared values on both sides, and mutually pleasurable on both sides. And his theory is, and he feels in his studies, he's proven this, the more a person is aligned with those 6 principles, the less they'll experience out of control behaviors.
Excellent. Great answer. Thank you. The next question, we have a few more, is, okay, so this person is saying, I am completely lost on how to help some clients who experienced sexual abuse and do not enjoy sex unless it is beyond rough. Are there any interventions that you'd recommend besides processing?
So let me talk about this. So I'm going to tell you something funny. I've been doing TikTok since December 3rd. My social media team said you should start to do it, and I've done it, and I freaking love it. It's so much fun. It's like the best thing I've ever done. However, I've done a few of them where I've talked about fantasy. I got on there one day, I was right here in my office, and I just did this video and said really quickly, sexual fantasies say a lot about you. You know how if you know someone's friends, you know about a person? Well, if you know about someone's sexual fantasies, you know a lot about a person. And then I went home. And within hours, it was like, I've had like 5 million people have watched that video and commented. And the reason I bring this up is I can't tell you how many people talk about, what does it mean when I get into rough sex? What does it mean when I'm into consensual non-consent? They call it CNC online, which I never respond to because there's a bunch of kids on there and, it's TikTok. I don't want to get banned or anything, but I can talk about it here. Some people do enjoy rough sex. They enjoy impact play. They enjoy humiliation. It's erotic, it's play. And so it may come from childhood, it may come from something, and it may not. But either way, I guess what I would do with those clients is help them make friends with it. It doesn't mean they're going to do it. It doesn't mean that their destiny has to belong to having rough sex. But I would encourage you as a therapist, which I've had to do, because consensual non-consent, like, I was out of my mind when I first heard that. What that means is two people are having a situation where if I say no, no doesn't mean no. You keep going. You go against what I told you, and that can be. But there's rules even in that, in the consensual non-consent, and there's negotiations around all that. So while we may get all amplified, like what the hell's going on here? That's not sex. It might be for that person. That may be their erotic orientation.
Well said. The last question is, what are some additional books or resources, trainings that you recommend for people that want to learn more about modern sex therapy?
That's a great question. Rachel, help me on that.
Yes. So feel free to check out our website, modernsextherapyinstitutes.com, and, search all of the great offerings. I think we have over 250 workshops that are recorded. We have suggestions on there. We have, explanations of the different programs. Feel free to reach out to me, Rachel at modernsextherapyinstitutes.com. I can answer any questions, set up a time to talk to you. I also give out my phone number, 561-379-7207. Always available to tell you more because, like Joe said, we don't want you to get left behind. You don't have to be a certified sex therapist. You don't have to go that route, but you do need to be sexually competent. You do need to be sexually informed because otherwise there's a huge, even if you work with just individuals and not couples, but more importantly, if you work with couples, there's just a huge chunk that people won't feel comfortable talking to you about, or you may be missing a big piece of the puzzle and you don't even know you're missing it.
Excellent. Everyone watching, make sure to check out the website. I'll include for Modern Sex Therapy Institutes, I'll include a link to that in the show notes, as well as Rachel's email and phone number. Thank you for providing that. And yeah, it was really great talking with you both today. Appreciate your time and sharing your knowledge with us.
I think I need a cigarette now. Just kidding.
Need a cigarette?
No, how after sex. Just kidding.
Right. All right. Well, thanks, guys. Appreciate you both. And hopefully we'll have you on again soon to talk about more. I'm sure there's just so many topics to cover under this topic. So yeah, looking forward to that.
Thank you
so much for having us.
And available to your community.
Absolutely. And to everyone watching, thanks for joining us today. Hope you got a lot of value out of this talk. I know I did. And keep an eye out for those links in the group and let us know if you have any follow-up questions. Dr. Joe and Dr. Rachel are both in the Therapist Toolbox community and would be happy to answer your questions. All right, until next time, I'm Dan Pierce from Mentally Fit, and we'll see you later.